Hi, my name is Kalliopi, as you mentioned, and I'm a pharmacist at the Maudsley Hospital. I work in the Medicines Advice Service, which is a national service for medication advice. And I've also worked for several years in the past in the acute assessment unit that we had, which was the addictions inpatient unit at the Maudsley. That closed some years ago, and that was a big loss in the trust. And so we're just going to, and Matthew.
Nice to meet everyone. Thank you, Turning Point. My name is Matthew Young. I'm known as Billy in my normal day life, so it's very weird to see Matthew up there, but it's Matthew for today. Thank you for Turning Point for inviting us. Thanks, Debs, earlier for kind of normalising and owning getting upset by this sort of stuff. I also get a little bit upset. My background is as, my first job was as a trainee paramedic, so at 21 years old I was dropped into Leeds City Centre witnessing lots of opiate overdoses, and I'm aware that there's probably people in the audience who've lost people through overdoses, so thank you for using your experience for the greater good. I think everyone needs to nod of the head to people who've lost people. So it's a matter that really means quite a lot to both Kalliopi and I.
Yeah, so I'm just going to set the scene a bit. So, as I mentioned, we did have an inpatient unit in the past that used to treat people in terms of, we had alcohol detoxes and opioid detox as well as opioid stabilization treatments. And the people that we used to work there had all the knowledge, and they were there 24/7, so they offered the support and advice to all the other inpatient wards and staff. And when that was closed, it was a big loss. So with time we realised that on the rest of the acute wards in the hospital and community teams, there was a lack of knowledge in terms of opioid risks, how to manage opioid use, and what to do in case there is an opioid overdose, how to advise people in terms of harm minimization, offer naloxone, supply naloxone. So the service users in our trust, they may not be in contact with the traditional substance misuse services, or maybe they are reluctant to go and get the advice or get the naloxone from the drug and alcohol teams that we have in the community. So that's why we realised there's an opportunity for us to offer the harm minimisation, teaching sessions, as well as teaching sessions on how to train people on naloxone and how to use it. So we started in around 2019 when COVID, 2020 when COVID struck, and we started with online sessions of training people, pharmacists, nurses, even doctors, and it started. So it was kind of a large-scale project, and it kept on changing. We kept on changing our teaching material as time went by, and from the feedback that we got and also the questions that we got, we realised that people were sometimes scared of using naloxone. In fact, they actually didn't know what naloxone was in the first place. And then when we told them, it will be available there, it will be in the Edvard's cupboard to offer it and to give it to people, people were scared of it. But with persistence and continued teaching, we've managed to change this, and Billy will go on and tell you all about it now.
Thanks, Kalliopi. I'm really sorry we've got that graph again, but I think it's really important. I think we all know, but this graph is pretty, it's pretty grim. We're at an all-time high for opiate-related deaths. This information alone to an audience of mental health staff is often a surprise, and I think that really highlights the lack of knowledge and experience that people within the mental health side of the health service have around the dangers around opiates. So we always show this graph in our training. We make no bones about it that this is a real public health emergency, and the mental health system has a huge role to play in this. It's not just for specialist addiction services. You know, our firm believes us in that no wrong door policy, and every consultation counts. So no matter where you work within mental health, whether it's psychiatry liaison, whether it's community mental health team, whether it's assertive outreach team or an inpatient psychiatric unit, this stuff is important and you need to know this stuff. Yeah, we took, so the NHS is really keen on different styles of project management. So the one they wanted us to use is called an A3 project management approach. So we started off with fairly realistic expectations, really. We wanted to try and train about 1/3 of our nursing staff. That SLAM is one of the biggest mental health organisations in the UK. We've got over 1,000 nursing staff alone. So we wanted to try and train 1/3 of those. Using traditional face-to-face training sessions, so Kalliopi would find ourselves going out visiting CMHTs, trying to go to psychiatric wards, going to lots of different teams, offering about an hour's Naloxone training, and then trying to get people to sign up to our patient group directive. So if anyone isn't aware of what a patient group directive is, it's a way to administer medications without prescription. Any of you who've had a flu vaccination recently, that's done through a patient group directive. So Kalliopi wrote our patient group directive for Naloxone, which basically meant that nurses and pharmacists are then, once trained, can issue Naloxone without the need of a prescription. You can see we had quite good success. So the kits, we monitored how many kits we issued in 2019. One of the biggest mental health trusts in the UK, we issued 2 kits in 2019 and 20. So we started doing our training sessions and we started to show some impact. Nowhere near your 4,500 kits, can I just say, but to go from 2 kits to 71 and then up to 220 in 23-24, we really demonstrated a significant change. The training was difficult. It took up a lot of our time. We would go to CMHTs and have very few people looking back at us. Care coordinators are very, very busy people. So we needed to change. We wanted to continue the project and have a bigger impact. So the solution, we're very lucky within SLAM. We have the Maudsley learning team, who are digital learning specialists. So we paired with we just call her the amazing Isabel Sampson, who's a digital learning specialist. She can't be here today, but she helped us to take our traditional face-to-face learning onto a digital platform. And we think there are other things available. There is kind of the exchange suppliers training, but we think this is the first kind of broadly bespoke training package for NHS staff around the use of Naloxone. And the reason we're here today is to try and spread the message. We don't want to own this. We want this to be shared amongst other trusts, non-statutory agencies. We are not going to be precious about this. We think the information is really, really important. So please come and speak to us after if you think your organisation might be able to make use of this package, because we're very, very proud of it. Few of the benefits. So staff can access the training at their own timings. They can start the training, they can finish and go back to it. It doesn't require trainer time. Obviously, it's required a lot of input in the lead up to it, but now that it's just, I keep doing that, I'm sorry, it just runs itself. Kalliopi and I can sit back and look at the numbers and look at the feedback and are not required to go out to kind of CMHTs on rainy Tuesdays, which was always a bit grim. The assessment is very closely linked to our nursing competencies. It's very closely linked to our medication competencies. So in terms of clinical governance, it ticks all those boxes. It was tested. It had a very successful trial with very positive feedback. And it was designed really importantly with the input of service users. So we had a lot of service user forums within SLAM who directly inputted into the package, including some really kind of moving service user accounts that are in the package. Okay, we've got a little animation. This is one of the animations that we're particularly kind of proud of. If we could just run the animation, thank you. We've really tried to stay away from kind of really didactic learning. It's really interactive. Isabel is the genius behind all this. So this, as you can see, this shows the naloxone coming in, displacing the opiates off the receptors, and it tells you the outcome for the patient. It also really importantly tells you that after 30 minutes, that naloxone is going to wear off, and the opiate is still circulating in the body, as you know, and will come back in, and a person is at risk of going back into overdose. That's just one of many kind of interactive slides that we've got in there. You have to wait for it to stop. Really important kind of reminder to people that the naloxone is going to wear off. You know, that people need to call the ambulance service. They need to monitor the patient once the patient's recovered. Okay. There we go. A little bit of feedback as well. Okay, we've also got videos in there, so you might recognize the voice in this one. So a little demonstration of the Prenoxad kit, which is the IM naloxone injection. As you can see, it comes in a yellow plastic case. It is sealed at both ends with a sticker. The best way to open it is to twist at either end. You'll hear a crack and you can open up the kit. What you have in there is a 2 ml syringe and 2 blue IM needles. The reason for 2 is that in case one gets damaged, you do not need to change the needle in between injections. We assemble the kit by opening the needle and placing the needle onto the end of the syringe. This one has what's called a Lure lock, so it locks in place by twisting. The Prenoxad kits can be administered into 2 muscles on the body. One is the deltoid and the other is the quadricep. You can choose whichever one is easiest to get access to. For the quadricep, be going into the outer edge of the muscle to a depth of approximately 1 centimeter, and the angle should be around 90 degrees to ensure that the active drug is entering into the muscle, where it will then be dispersed around the body. So if removing clothing is causing unnecessary delays, the Prenoxad kits can be administered through clothing. As again with the quadricep at the deltoid, you need to go in at an angle of 90 degrees to a depth of around 1 centimeter and administer the dose as required. As you can see on the side of the Prenoxad syringe are graduated doses. These are pre-marked to make administering separate doses easy. Simply go from 1 to 2 to 3 as required, with approximately 2 to 3 minutes in between doses, depending on whether the patient starts to recover or respond. You do not need to resheath the needle between doses. Please be mindful to place the injection somewhere safe to avoid needle stick injury. As everyone probably knows, we've also got nasal naloxone now, which is a fantastic addition. I think lots of people are quite concerned about giving injections. So we've included the Nixoid kit in our little demonstration, if you can run that one. Thank you. The newer version of naloxone comes in a nasal spray. The packs come in a set of 2, so you may find it in a box or you may find it in a single blister pack. Simply peel back the back of the box and carefully remove the nasal spray. Be very, very careful not to accidentally trigger the nasal spray. The way it is triggered once it is in situation is by pressing the plunger, holding between the thumb and forefingers and pressing the plunger once the nozzle is inserted. To try and build some real quality learning into the package, we also have an assessment at the end, which is drawn. We have a bank of around 30 questions. So it randomly generates about 12 questions out of 30. It's trying to prevent people from cheating. Where people then, it's got 90% pass rate. So people need to score 90% to pass and complete the training. So we were really keen to have an assessment in there to try and maximise the learning outcomes for people. The assessment is very closely linked to our mitigation competencies within the trust, so it's quite clinical, but we are preparing a less clinical version that will take out the PGD aspect that we're hoping is going to be more applicable to lots of different environments. These are example questions. So again, the questions are kind of interactive. We've got things around kind of BLS protocols in there. We've got things around injection sites, things around risks around opiates, signs and symptoms of overdose. So it's a real kind of, it's not just about naloxone. There's actually a lot of harm reduction knowledge and learning in there for participants as well. So we're pretty proud of it. It's got a lot of mixed media in there to try and reduce the kind of boredom factor. We've managed to keep it under an hour, so I think the average completion time is about 47 minutes. So people are hopefully really engaged, and there's a lot of learning in there for people. People can't rush through it, as sometimes you can on e-learning packages. You can't just click forward. There's minimum allocated times to some of the slides. And then it culminates in the assessment, so people are really asked to think about their learning before completing the course. We are very proud to also say that the Trust has also made this now compulsory for all our nursing staff and pharmacists. So as far as we know, we're the only mental health trust that has compulsory naloxone learning for our staff force. So since launching, so we launched in June of this year. We've had over 800 successful completions. So anyone who works in the NHS who's launching some training, I strongly advise you to do it just before appraisal season, because everyone has to have 100% of their learning complete to do the appraisal. So appraisal season's always July. We launched in June, and yeah, 800 staff members later, we're up to about 50% of our nursing population have now completed the training. So we have an aspiration to identify all patients who are at risk of opiate overdose in the Trust, and to be offering take-home naloxone to all of those patients. We're just about to launch on an alternative platform so that other non-SLAM staff members can access this training. And yeah, that's why we're here. We want people to make there's no point in duplicating work. You know, we want other trusts, other organisations to get involved, and please come and talk to us if you think you can make use of this package. We'd be delighted to speak to you. Thank you.